Welcome to TS and the Heart. This is going to be a great two-part session. And I'm very pleased to introduce our speaker today, Dr. Siddharth Prakash. He's an associate professor at McGovern Medical School, the University of Texas Health Science Center at Houston. He organized the UT Health Adult TS Clinic and coordinates the UT and TSSUS Research Registries. He's board certified in cardiovascular disease and internal medicine, and his clinical interests center on the bicuspid aortic valve, thoracic aortic aneurysm, and adult congenital heart disease in patients 17 and older. His research concentrates on the genetic causes of bicuspid aortic valves and related congenital abnormalities involving the left ventricle outflow tract and aorta. And he's a fellow of the American Heart Association and the American College of Cardiology, and he's also the chair of our Scientific Advisory Board. So welcome to the stage, Dr. Prakash.
Welcome, everybody. Are you having fun? Okay, good. I'd like this to be a very fun session. I know cardiology can get very heavy, and so I really want your input and help in making this interactive so we all learn from each other, because honestly, I've learned most of what drives our research from you all. You know, the questions that we get at this conference really turn into research projects that answer questions that are important to you. So it all starts with you, and that's why I don't want to talk the whole time. I can't talk the whole time, but if you post your research questions or post any questions ahead of time, then we can get to them in the second half. So if there are any burning questions you have about your own heart that might apply to other people, obviously we're not here to give you specific general medical advice. I can't do that. I'm not your doctor in most cases. Some of you I know, but in many cases this will be general questions that you think might be on everyone's mind that you want to know. Or if you have an idea for research that we really should look into, please put them in the VVox. This is the ID, right? The ID that they need to use to log in. It's 140-186-573. So you can take a picture of that. If you do that anytime during the talk, at the end, I'll get to those and we'll answer them, okay? And you can also, of course, say it out loud if you want to do that. All right, did everyone get that? Let's keep going. All right, so this is TS in the Heart. I'm going to go through a beginning presentation about what we currently know and kind of want you all to know about the heart, and then we can talk about research. So we'll start with an overview of heart and blood vessel problems. I'll go into what you should know about your heart health, and then the research part. Okay, so the thing that I work on the most, as you heard, is aneurysms and bicuspid aortic valve. Those are the two most common heart conditions in people with Turner syndrome that they are born with. So about 1 in 3 people have a bulge in their aorta. This bulge is also called an aneurysm if it gets to be a certain size. One of the research areas that we're working on is actually defining what an aneurysm is in a person with Turner syndrome, because we don't actually have a great definition. And the reason for that is that the aorta varies in size based on how big you are, and so we have to adjust, if you're a smaller than average person, exactly what that diameter means. And so many of you might have had this experience where your aorta, your doctor says, well, your aorta doesn't look right, but I'm not sure what's going on. I'm not sure where you fall. And that's the reason, because we really don't have a good definition, and we need to learn more about that. But based on the current definitions, it's about 1.5 times what we expect the aorta to be based on your age and body size. And that's defined as an aneurysm. And most people with aneurysms also have other heart problems that we need to look for, like a bicuspid aortic valve. So this is what a picture of your aorta might look like if you have an aneurysm. Most of the aneurysms are involving the two parts of the aorta that are closest to the heart. The root, which is where the heart arteries come off and where the aortic valve is, and the ascending aorta. The ascending aorta is kind of, if you think of the aorta as a candy cane, this is the short part of the candy cane. All right, so here's that issue that I talked about. Small people have small aortas. Big people have big aortas. That's pretty understandable, right? Well, what if you're a small person who has a big aorta? Notice that if I measured the two aortas in the center and on the right, I'd get exactly the same number. They're the same size. So what would be a normal size for a big person would be big for a small person, but they're the same number. And that's the situation that people with Turner syndrome often find themselves in. Your doctor will say, well, the measurement looks normal, but your aorta looks big. What do I do with that? And so I'm here to say that the best way to deal with this is to adjust the aortic diameter to body size. Some of you might have heard about this. It's called a Z-score in kids, or it can be called an aortic size index in adults. And this is kind of what we do. So your aortic size, if you mapped everybody in this room, would kind of form a bell curve, where you had some people at the low end on the left and some people at the high end on the right. Usually the right side of the curve is what we're concerned about, because that is a higher than normal aortic size for your body size, and that's what we define as an aneurysm. An average size would be in the middle, close to 0. So when we talk about Z-scores or aortic size, we're thinking about this curve and where you fit on it, if you're in the middle or if you're close to the edge. And that's how we define risk in Turner syndrome right now. All right, so practically speaking, when someone measures your aorta and you get a number or you get told that your aorta is big, they're looking at a picture that looks like this. This on the left is a cartoon of what a typical aorta looks like, and on the right is a picture of an echocardiogram, an ultrasound of the aorta. Notice that the only thing that we see here, if you think of the aorta as the candy cane, is the tip of the candy cane, the small end. We don't see any other part of the aorta. That's important because, as I showed you, in many of cases, the bulge in the aorta doesn't happen at the tip of the candy cane, it happens farther up. So if you get an echocardiogram as a Turner syndrome patient, you may only see the normal part of the aorta, but there could be a bulge outside that place that they're looking at. So that's where other kinds of imaging come in that could be important to diagnose an aneurysm. But anyway, this will show you the root or sinuses of Valsalva and just above the root, but it won't show you the whole ascending aorta in many people. This is what a typical MRI scan looks like. An MRI is another type of image that we can use to look at the whole aorta, and in here we can see much more of the ascending aorta. So that number 4, that is where most of the bulges in Turner syndrome happen. And notice how far it is above the root. So a person could have a normal aortic root down at number 3, but have a bulge at number 4, and would have a normal echocardiogram, but could have an aneurysm by an MRI. So that's why sometimes different kinds of pictures of the aorta are necessary to diagnose an aneurysm. So the points to remember about aortic measurements. Always know not only how big your aorta is, but which part of your aorta is biggest. Is it your root, ascending aorta, or somewhere else? Because that determines what kind of pictures are best for you. Know when your next set of images are due. If your aorta is normal, you may only need pictures of your aorta every few years, but if you have an aneurysm, your doctor may want you to come back in 6 months or less to see if it's changing. It's very important to go to a center that specializes in imaging patients with aortic problems or congenital heart disease, because they will know about these factors. If you go to a center that's not experienced, they might get an echocardiogram and think it's enough when they haven't seen the whole aorta. Remember that there are 2 options for scans, something called a CT scan or a CAT scan, and an MRI. In young people, we prefer MRI scans because they don't use radiation. If you have a family history of cancer, exposure to radiation over time can increase your risk of cancer. So we prefer to use MRIs. Usually, we start MRIs around age 15 when you can first use an MRI without being sedated, because sedation carries a risk. And we recommend that for adults. Okay, so this is what I look at as a cardiologist, an aortic valve opening and closing. And we have two types of aortic valves here. On the left, you can see a normal aortic valve, and it kind of looks like a Mercedes-Benz that has 3 equal spots, and it opens and closes symmetrically. On the right, you have a bicuspid aortic valve of the type that we typically see in someone with Turner syndrome, where 2 of the 3 cusps are kind of fused together, and it opens like a fish mouth. It doesn't open nice and even. That abnormal opening puts wear and tear on the valve. And what typically happens over time as you get older is calcium builds up on the valve and it gets sticky. It doesn't open well. That is called aortic stenosis. It's a condition that's very common in people with Turner syndrome and bicuspid aortic valve. It can happen faster in Turner syndrome, in fact, than in people without Turner syndrome. They develop aortic stenosis at younger ages, and if it gets sticky enough and the valve isn't opening well enough, sometimes you need surgery to replace your aortic valve. So what happens when the valve wears out? Your heart can get very thick because it's having to force blood through a valve that doesn't open well. This thickness can lead to feeling short of breath, getting high blood pressure, or even heart failure. So it is very important, if you have a bicuspid valve, to know how well it's opening and if you're at risk of needing surgery, because that determines how frequently your doctors would need to follow this. The best way to follow this is with an echocardiogram, because we can see the aortic valve open and close very well with the echo and be able to tell you what your risk is. So related to the bicuspid aortic valve is coarctation of the aorta. And if we see someone with Turner syndrome who has a bicuspid aortic valve, we look very carefully at the aorta to make sure that there isn't a pinched-in area at the aortic arch. So the aortic arch is the top of the candy cane. That's where the coarctation happens. Notice that it doesn't happen close to the heart, and what that means is you can't see a coarctation with an echocardiogram. You need to have a CAT scan or an MRI to see that. We can detect blood flow problems related to the coarctation because it pinches the aorta in a narrow area, and that restricts blood flow to your legs. So people with coarctation that is serious have low blood pressure in their legs and high blood pressure in their arms and chest. Over time, that can lead to damage to the arteries. It can put you at risk for stroke or heart attack. So it's very important, if you have coarctation, to get that treated before it causes damage. And typically, if you're born with coarctation, that would be fixed as a baby, but it can also redevelop over time in people who've had it fixed as a baby. In adults, we do see this. It's called recoarctation, and it just means that the area that was repaired got narrow again and is causing blood flow problems. So it can become symptomatic anytime from birth through adulthood, and there are effective treatments now to do this with a stent inside the blood vessel that doesn't require open chest surgery. All right, so this is a cartoon that shows you what a coarctation looks like. It's a narrowed area just at the top of the candy cane, and when that blockage happens, it affects other blood vessels in the chest. That can go back to normal once the coarctation is fixed. Most people with coarctation have other heart and blood vessel problems, like bicuspid aortic valve. So we also want to treat those things as well, because the risk adds up if you have more than one type of problem. Someone with bicuspid aortic valve and coarctation has more problems than someone with just coarctation. So if you have bicuspid aortic valve or coarctation, the most important thing that you should do is regular visits with a cardiologist and knowing what kind of images you need to check your heart valve and the coarctation to make sure it's not coming back. All right, related to the coarctation and the bicuspid valve is high blood pressure. About half of people adults, and up to 60% actually in the current guidelines, were found to have high blood pressure at screening. So it will happen to more than half of people in this room, and it doesn't cause any symptoms. You can get high blood pressure even if you don't have any other heart or blood vessel problems, and it can put you at risk for stroke or heart attack. So we do strongly recommend in the current guidelines that everybody with Turner syndrome, beginning in childhood, has their blood pressure checked every year. If your blood pressure is high, you may need to go on medications. The top number on your blood pressure should not be higher than 130. 130 is the number to remember. If your blood pressure is higher than that, you may need to go on medical treatment. And this can happen to anybody, regardless of how thin or heavy you are, or if you have any other medical problems. It's part of Turner syndrome as a characteristic. So when we think about the big risk that you might have heard about, which is a tear in the lining of the aorta called aortic dissection, we know what the risk factors are in Turner syndrome. Fortunately, even though it happens in Turner syndrome, overall aortic dissection is still very rare. It's about 1 in 1,000 people with Turner syndrome. So it's not common, but it's more frequent than we would see by 100 times in the general population, okay? So just because you have all these things doesn't mean you're at high risk for aortic dissection. But if you have a list of these things like bicuspid aortic valve, high blood pressure, coarctation, or other heart problems, you may be at risk, and your doctor should see that risk and take steps to prevent that risk. One of the more common things that we try to do is treat the high blood pressure. We might also use special medications to slow down the rate of an aortic aneurysm getting bigger. Both of those things we think can prevent dissection, but that's another area that we don't know much about in Turner syndrome, and we're trying to do research to figure it out. So some other things that you might have heard about that are not quite as common or quite as serious in terms of their outcome, but still happen in Turner syndrome. One of them is an abnormal vein in your chest that can drain into the wrong side of your heart. That's called a PAPVR, or anomalous pulmonary vein. It happens in about 1 in 7 people with Turner syndrome, and it can be very hard to figure out because unlike the problems I told you about, it doesn't cause any dramatic symptoms, at least in childhood. It usually causes symptoms in young adults who might start feeling short of breath or getting palpitations or passing out. Those are the 3 most common symptoms. If you have any of those things, you need to get a special test called a cardiac MRI to detect abnormal pulmonary veins. They can't be seen by echocardiograms. They can't be seen even by regular CTs or MRIs. But we can sometimes get clues because when you have one of these problems, the right side of your heart will swell up. And if we see that on an echocardiogram in somebody with Turner syndrome, we're almost pretty sure that they have one of these abnormal veins. We can confirm it with a cardiac MRI test. So these are very easy to fix, and they don't even need open heart surgery in some cases. But even with the surgery, the recovery is excellent, and we can stop the abnormal flow and prevent the symptoms. So the key here is just diagnosing them before they cause serious problems like passing out. And then many of you have asked me about regular types of heart disease that everybody gets, which are also more common in Turner syndrome. And these are coronary artery disease and stroke. The reason why these are more common is because the risk factor for them is cholesterol buildup, and high cholesterol and diabetes, which both predispose to these things, are also more common in Turner syndrome. So these are caused by atherosclerosis, or buildup of cholesterol plaques in your arteries. It happens beginning in childhood, but we don't see it show up until after age 45, when these things are the leading cause of death in Turner syndrome. So I would tell everyone who's over age 35 with Turner syndrome to start screening for these things with checking your cholesterol, make sure your blood pressure is controlled, because those are the best ways to prevent these things from getting worse and causing strokes or heart attacks. So the key here is, to prevent heart disease, check your cholesterol levels, I would say beginning around age 35 in Turner syndrome, everyone should know what their cholesterol is and take medications for it if it's high. If it's high, you can change your diet also. I recommend that, and for my patients who are older, usually beginning in their 40s, to screen for heart artery blockages because they are relatively common and sometimes they don't cause any symptoms. But if we know about them, we can start to reverse them with some of these medications and diet changes. The ways we screen for heart artery blockages is with what's called a heart stress test or sometimes a special kind of CT scan. You can also screen for neck artery blockages that cause stroke using ultrasound or CT scans. If the blockages are found, these can be totally treated and strokes and heart attacks can be prevented. So the most important thing here is to be aware of your risk and to get regular screenings. So as you might know, we just completed the 2024 International Guidelines for Turner Syndrome. These are some of the take-home messages from the guidelines. We think everyone needs an echocardiogram when you're diagnosed with Turner syndrome, regardless of the age, to pick up any heart abnormalities. Based on that, you might need additional images, like I talked about, if we think you might have a coarctation or abnormal veins. You should see a cardiologist at least every 10 years and probably more often if you have one of these heart problems. And if you're planning to try to become pregnant, we recommend redoing all of these tests to make sure that it's safe, your body is safe to have a pregnancy. Control your blood pressure and cholesterol, and watch out for atherosclerosis of your blood vessels after age 45. So these, in the guidelines, we actually go through when you should see a cardiologist. This is going to be the current version is really for doctors, but we're going to make a version for patients as well. But we spell out which ages people should go see a heart doctor and why they should see one. For example, on this slide, you can see beginning before birth, if there's any abnormalities on the fetal scan, we recommend consulting with a cardiologist. After birth, if there's anything that they need to follow up on, because sometimes it's hard to see the heart in the mother's womb, in order to be able to determine if there's any problems with the heart after birth. At age 4 to 6, because as the child gets larger, it's easier to see some of the abnormalities, like a bicuspid aortic valve, which is difficult to pick up in the baby. At age 9 to 11, and then beginning in the teenage years, you might start to look for other images like a cardiac MRI or CT to look at these other aortic problems. And of course, I deal with patients who are transitioning to adulthood, so we get a visit usually that is referred by a pediatric doctor, and we talk about things that people need to do to take care of their heart and blood vessels as young adults. So we also talk about why you should see a cardiologist. In most cases, everyone needs to see a cardiologist at these different times in their lives, but there are some specific things here on this list that also help your doctors refer you to a cardiologist, because we want to see you. We want to know if you're taking a new medication or if you have new symptoms that might be caused by heart problems. That can be picked up early, and we can prevent strokes and heart attacks. So we have a long list of what people might need to see a cardiologist for. And these are the ones in yellow are the ones that everyone should do at diagnosis and then routine follow-up through childhood. So we also answer the question in the guidelines, how often do you need to see them? And this is really, again, based on your risk. So the key here is, do you have any sort of heart problem, a bicuspid aortic valve, coarctation, or high blood pressure? If you don't have any of those, you may not need to see the cardiologist as often, but everybody needs to see the cardiologist at regular intervals. And in childhood, we recommend that it be every 3 to 5 years, or as frequently as every 6 months, depending on how your risk falls in this diagram. And you can see that the Z-score for the aortic size is there. a Z-score, like I mentioned, is a way to adjust your heart size to the body size. And the Z-score cutoff is 3. So if your number is above 3, that puts you at a higher risk because you have an aneurysm of the aorta. And that we have a similar table for adults. So this is over 15 years. Again, there are more ways to adjust aortic size for body size in adults. And we think that we need to do more research to find the best way to do that, to get a score that really predicts risk. We're not there yet. But there are 3 possibilities, and we recommend that people look at those because some of them change a lot depending on if you gain or lose weight, and they may not be accurate for some people. But we have risk categories here, and as you can see in adults, it runs from every 5 to 10 years that you need to see a cardiologist to every 6 months. So these are the ways that we adjust aortic size to body size in adults. The Z-score, the aortic size index, which you're probably familiar with, and then something called the aortic height index, which is not using your weight, but is using just your height. That seems to be more accurate in early studies, and we're going to do more research with the registry to find out if we should be recommending this in future guidelines for Turner syndrome. So high blood pressure, again, we recommend checking it every time you visit the doctor. We have the recommended blood pressures here. So in adults, if your top number on the blood pressure is over 130 or your bottom number is over 80, you have high blood pressure. And then we have a way for doctors to diagnose and treat the causes of high blood pressure. Sometimes it's fixable if we know what is causing the high blood pressure. Okay, so the take-home points here. Know your heart. Were you born with any heart problems? Do you have a large aorta? And when do you need to get your scans to look for heart problems or heart problems changing? Know your blood pressure. If you had a high reading, you should be checking your blood pressure at home to make sure that your blood pressure is under good control. And then if you're going to have surgery or if you're trying to start a family, make sure that you recheck your heart and blood vessels to make sure that nothing has changed. Okay, and then this is the end of this section. I just want to promote the idea that we want everyone to have access, that's the goal, to a TS-specific clinic. We're not there yet, but we're getting closer. I think there are more kids clinics than adult clinics, but our clinic is trying to change that. We want to grow this network of clinics so that everyone can go to a specialty clinic that is one stop for all your healthcare needs, that has providers that are familiar with Turner syndrome to make some of these decisions and help guide you, and also to promote connections to the community, like here, but across the country. So we want to make that a reality for all people with Turner syndrome, and with your help, we're getting closer. Okay, and this is the information for our clinic in Houston, where I work. We serve people from all over the country who don't have access to a Turner syndrome clinic in their communities. We're always welcome to, you're welcome to ask questions, even if you can't come see us. We would love to give you advice. So that's our information. We have a website where you can send in questions, actually, to any of the providers. And Dr. Rivera, who is our pediatric colleague in the clinic, she's been giving a talk here too. She's an endocrinologist and works in the clinic. Okay, I think I'll pause here because I'm tired of talking. And does anyone have any questions that we can start with? Should we pull up the questions? Should we do the poll? Okay, let's do the poll. I think we're going to have another opportunity. Okay, so I want to promote the idea that we answer some of the questions that I raised in the talk and probably some things you're wondering about by research. And we cannot do research without your participation. So these questions are for everyone to answer. Have you signed up for the Healthy Heart Project or the Turner Syndrome Research Registry? If you haven't signed up, there are tables right outside this room where you can sign up for the registry. And this registry allows us to really grow our research community. The information in the registry is used by researchers to learn more about Turner syndrome, including about heart and blood vessel problems. If you participated in the Healthy Heart Project at one of the previous meetings, we want you to sign a consent form to transfer your information into the registry, to grow the registry. As many of you might have heard, the Healthy Heart Project is going to become part of the registry in the future. And so this will allow us to retain all the information that we accumulated over the last 20 years. Otherwise, it will go away. So if you participated and you haven't signed the consent form, that's also on the table outside. Okay? And if you've signed up for the registry, remember to complete all the surveys that we send to you. The surveys are how we learn about you and how we update your health information. There's a current new version of the surveys that you should have gotten in your email if you're participating in the registry. So check your email for an email from the TS Research Registry. And please fill those out, because that's how we learn about our community. Okay, so that's good. We have some work to do. And it sounds like we'll expect some visitors at our table today. I'll be at the table all day after this, and you're welcome to come up and ask questions. All right. Do we have any questions that are posted? A couple more questions. Okay. There we go. So have you filled out the latest survey? These surveys came out in the last 2 months. To give you an idea, it should be a fairly recent email. So we have some work to do, but that's okay. They've only been out for a couple months, and this is your opportunity to contribute. We're working on new ways to remind people. We know you get a ton of emails, we all do, and sometimes it's easy to miss them. So in the future, we might sign you up for text messages to just remind you, hey, we have a new survey. But remember to check your email because it can be easy to miss. The other question is, we are going to present updates from the research that we have done using your information. This afternoon at 3, you can see what your information, your contributions have done for TS research. I can tell you in the last year, it's been really exciting. Besides the guidelines coming out, we've also published six papers based on your information in the registry. We'll go over what those are, the ongoing research projects that you can contribute to, but we want to know, do you have any ideas that we should be following and presenting at future meetings? So please post those, and we'll definitely get to them this afternoon as well. Okay. Okay. Just a few ideas. This just shows how much interest there is in research in the community, how many questions there are out there. And many of these are going to be outstanding projects, I can already tell just looking at this. We do have some ongoing research that addresses some of these that we will go over this afternoon. So I would stay tuned, and really, if you're interested, come to that session because you will see how we put your ideas into action. Okay, good. I will look at these and get to them as best we can. All right. So do we have any burning questions that people want to share? Yes. Yeah, sure. That's great. So the question was, what is the aortic height index and how do you figure it out for yourself? So the aortic height index is the diameter of the aorta in centimeters divided by your height in meters. And it is basically, it's basically a ratio. We don't have a lot of information about it yet, but in the discussion for the guidelines this summer, there was a lot of interest in the aortic height index because we noticed that people who have gained and lost weight, which happens frequently, in that scenario, their aortic size index can fluctuate quite a bit over a short period of time. And it can make it very confusing for people because let's say you lose 20 pounds, a good thing, right? Well, your aortic size index can change by a lot, from going to a borderline aortic size index to much bigger, right? Because your weight is at the bottom end of that index. And when you lose weight, your ASI can increase. So that is, it can be very difficult and frightening for people to experience that, and we wanted something that is independent of weight. Height index is something that we're looking into, and in the future versions of the guidelines, as I mentioned, we hope to have more research to support that. Is tachycardia common in Turner syndrome? Yes. High resting heart rate is probably one of the most common things that we see in electrocardiograms. We did an analysis of the electrocardiograms from last year's Healthy Heart Project. We'll present some of that information at our research update, and that's part of it. We saw very high resting heart rates. What is the risk of stroke due to estrogen replacement therapy? Again, another area of interest. That's one of the reasons we launched our Estrogen Experience Survey. If you noticed, the Turner Syndrome Research Registry sent out an email about this recently. We want to know what types of estrogen people have used, what hormone replacement therapy, and their experience with side effects, including any stroke or complications. We want to hear from the community because we think that more research needs to be done in this area. It is an area of concern, and it's something that we don't have a lot of information about. Where did my TS passion come from? From being surrounded by a lot of people who had interest in the X chromosome. So I started out as an X chromosome researcher, and I became interested in how sex chromosomes affect disease, and then became a cardiologist. So I've had a 25-year-long journey from X chromosome science to Turner syndrome. And along the way, I met a lot of incredible people who have mentored me, but really, it flowed naturally from my basic science interests and work. How long is the wait time to get an appointment in Houston? We can usually get people in within a few weeks. If you're traveling from outside, we try to set it up so that you can get your images and testing on the same day. And sometimes that takes a few weeks. How does recoarctation occur? Do we know? We know that it tends to occur at the site of previous repair because when we look at the aorta in that area, it's often not normal, it's very thinned out, and we think that those abnormal cells in the aorta can sometimes stick around, and that leads to the recoarctation in some people, and it's more likely with certain types of previous surgeries than other types of repair. Fortunately, it's becoming rarer because doctors are learning how to, figuring out how to prevent that from happening more effectively. Besides blood pressure, what is the most important thing for somebody who has had open heart surgery for aortic dissection? So blood pressure is, again, the most important risk factor that we know of that we can control. But what I would say is after aortic dissection, the other factor that comes into play is regaining your quality of life. It is a huge trauma, and it takes many months to years to recover. So access to things like cardiac rehabilitation, physical therapy, and emotional support after a dissection are just as important as the physical manifestations, because it takes a long time to heal mentally and physically from a dissection. And it's important for you and your loved ones not to underestimate that healing time. Can heart issues arise at any time? I'm going through these as they come up. We'll try to get to more of them later. So if I missed your question, I'll get back to it. Heart issues can arise throughout the life in Turner syndrome. And as I showed you, there are different heart issues that can happen at different times of life, depending on whether you were born with them or whether you acquire them. But the message that everyone should take from this is that heart issues are a lifelong issue, and you should seek regular follow-up with a heart expert to make sure that you understand your risk at all times. Let's see. I'm going to skip the top one because it's a little long. I'm going to go to start with these shorter ones. Have you found a correlation between TS and left aortic arch with right aberrant subclavian artery? So this is a type of abnormality of the aorta and the top of the candy cane where the head and neck vessels come off. It is more common to have these types of problems in Turner syndrome. We have several examples of people with abnormal arteries in the arch, and we think that that is related to Turner syndrome. And we also think that in people without Turner syndrome, some of these abnormal arteries do increase the risk for an aortic dissection. But it's not clear if the added risk is true in Turner syndrome or not at this point. We used to think that some of these abnormalities did increase risk, but looking at the data, we don't have strong evidence at this point. That's something we're looking into for the future guidelines. 45X is increased risk of dissection. So a 45X karyotype has been associated with an increased dissection risk. It's one of the risk factors we look at. It's not the only one, and it's certainly not, we certainly don't have a great predictor for dissection. Even when we include all of those risk factors, we certainly need additional risk factors to understand an individual's risk. These were developed based on looking at large groups of people, hundreds of people with Turner syndrome, only a few of whom had dissections. So an area of research is to understand additional factors that would help us to predict for an individual. How do you prevent an aortic stenosis? I get that question a lot. If you have a bicuspid valve, as we talked about, you're at risk for the valve wearing out and for that to cause thickening of the valve, trouble opening. We call that aortic stenosis. Usually that happens when the valve calcifies, and there are certain lifestyle factors that may make that more likely. One of the more common ones is kidney problems. So if you have kidney failure due to a structurally abnormal kidney, which often happens in Turner syndrome, your valve can calcify faster. If you have high blood pressure or diabetes, your valve may also calcify faster. So the message is to control the factors that we know can increase the rate at which calcification of the valve occurs. Controlling blood sugar, controlling blood pressure, and having a balanced diet with antioxidant foods may slow the risk of valve progression. But again, that is based on people without Turner syndrome, and what we really need is more research in that area to find an ideal method to prevent aortic stenosis in Turner syndrome. All right. Can coarctation happen later in life if you have never been diagnosed with it? It's not likely, but what can happen later in life, in particular in Turner syndrome, is that you can get a bulge in the aorta at the place where coarctations can form, usually in the chest, just outside just after where the top of the candy cane is. And that can happen anytime in people, even decades after they've had a history of coarctation, or in people who have high blood pressure or other risk factors. So it's one of the reasons why we recommend additional scans of the heart and aorta throughout life, because sometimes people have a risk to develop these later in life. All right. Long-term effects of hormone replacement and cancer rates. So that's not directly related to what we're talking about, but it's another area of research. Like I said, we need to understand better about how hormone replacement therapy affects things like high blood pressure and heart disease in Turner syndrome specifically, because a lot of people who are at risk for, say, atherosclerosis, like I mentioned, causing heart attacks and strokes, also take hormone replacement. And we need better information about how that affects risk. All right. Should my daughter, who has had a normal echocardiogram at age 13, also get an MRI? I mean, as we talk about in the guidelines, an MRI is not necessary at age 13 for everyone. We would only recommend that if the child can undergo undergo an MRI without sedation, and there isn't a pressing need, and there is some sort of pressing need to do the MRI at age 13 instead of waiting until 15 or 16. So the answer is probably no, but it would depend on the risk factors. Like, is there an urgent reason to know now versus 2 years from now? Will that make a difference? It's worth asking that question with your doctor if they propose doing an MRI, because MRIs can be very difficult in kids without sedation. Can we have our cardiologists send the research project or testing? So one thing that I'd like to make clear is that the Turner Syndrome Research Registry is self-reported data. So we don't ask you to send in your echoes, MRIs, or CTs in the research registry itself. However, if you join the registry and we find out that you have a condition that we want to do a research project on, we will contact you and we will let you know exactly what we need from you. So in some cases, we do ask for your old heart and blood vessel images, but you won't be asked to upload them to the registry or anything like that. It will be all done through a separate research study that you will be asked to participate in. Okay. Does family history of diabetes and hypertension increase a woman's chance of getting those? Yes. So family history does play a role, and if you have Turner syndrome, you can kind of think of it like an amplifier of family history. So you're at more risk to begin with, and then if you have family risk, you add that to the risk. So having a risk of heart disease in your family does count, but we're not sure exactly how much more having Turner syndrome increases the risk at this point, but it definitely does. So I always take that into account when counseling people about their risk. And we recommend starting to screen for heart disease at an age that's around 10 years before whoever in your family had a stroke or heart attack. So if you have people in your family who had heart attacks or strokes below age 55, which is considered young, then you might need to start screening in your 30s instead of your 40s. Okay, so can you describe a Boston Z-score versus a standard Z-score? So Boston Z-score is used in kids, and we have something called a TS-specific Z-score that some of you might have heard of, which is a little different than a standard Z-score. It's specifically for Turner syndrome, and it comes out of the research from the Healthy Heart Project, actually, that you contributed to. So the TS-specific Z-score is what we recommend over the Boston Z-score for kids. We don't have any information like that for adults, like I mentioned, so we're still looking for the best way to adjust body size, aortic size to body size in adults. You mentioned medications to slow the development of an aneurysm. Can you elaborate? Yes. So we base all of our recommendations right now on other people who have aneurysms, and that's mainly people with Marfan syndrome. As you can tell, people with Marfan syndrome are nothing like people with Turner syndrome, so this is a problem. We don't have great recommendations based on specifically for Turner syndrome. So what I'm asking our colleagues to do is to do research on that, and we might contact you to participate in a research study about what is the best medication for Turner syndrome. But right now, that medicine is the one we use for Marfan syndrome. It's beta blockers. So many of you might be on a beta blocker. Who is on a beta blocker in the audience? That's like metoprolol, atenolol. It ends in lol. Okay. So those are very commonly used, but it's used because we don't have really experience to know what the best medication is yet for Turner syndrome. How common is bundle branching in TS? So bundle branch, I think you're referring to a type of heart tracing abnormality on an electrocardiogram. That usually indicates a problem with the heart. It's not super specific, but if we see that, we think that somebody has a heart problem and we need to do another test. It is not that common, but it is more common in Turner syndrome than in people without Turner syndrome. And again, it would be another risk factor that we would look at. We're going to talk about how common it is at the research session this afternoon. So that was it's a great way to promote that. If you're interested, we're going to have a session on electrocardiograms. ECGs or EKGs are still the most common screening tests in Turner syndrome, and I strongly urge everybody to get one on a regular basis because a change in your ECG can actually tell us a lot about you and whether you need to have more testing done. Okay, so what is BAV with appearance of trileaflet? I think this might be referring to a kind of bicuspid aortic valve that is hard to diagnose. It means that it doesn't look like a complete normal valve, and it doesn't look like a bicuspid valve. It's kind of in between. Many of these are missed. Many of you might have had the experience of being told that your valve is normal at some point and then being told that your valve is bicuspid at another point. Did anyone have that experience? Yeah, quite a few. So that's not an uncommon experience for people with a bicuspid valve. And the reason for that is some bicuspid valves, they look almost normal, but there's just a small area that's fused together. Those are still bicuspid. They're just as important to know about as the ones that look really abnormal and very thickened, because they still can cause risk for aneurysms and other problems. So unfortunately, we're not great at diagnosing those, and sometimes you need a special test like a cardiac MRI to be sure. That is more likely to happen if you go to see a heart expert at one of the Turner syndrome clinics, and it's another reason to get specialty care. Okay. Is there a recommended age for cardiac MRI? We recommend a cardiac MRI in anybody who has an abnormal echocardiogram at the earliest age when they can do an MRI without sedation. In most kids, that's around age 15. So in some kids, it might be earlier. It really depends on the kid. But we definitely recommend everyone who has a history of heart problems with Turner syndrome to have at least one cardiac MRI in their life. And that can be a transition. If I see them and they haven't had an MRI, I'm going to recommend an MRI. It's not for everybody. If you have a normal heart and your echo is normal and you've never been told you have a heart problem, you probably don't need an MRI. It's only for those who've been told they had a heart problem. Are there any concerns if you have one high blood pressure? So you might go to the doctor's office and you tend to be anxious and your blood pressure is 150 in the doctor's office, but when you go home, it's 110. Does anyone have that kind of scenario? Yeah, it's really super common. And the reason why it's common in Turner syndrome is because we're anxious, right? You get super anxious when you go to the doctor, especially if you have a bicuspid valve. You're worried that you'll get bad news. Your blood pressure shoots up. Your doctor says, oh my God, you have high blood pressure. You get more anxious, right? That doesn't help. So what we recommend is to do home blood pressure or 24-hour ambulatory blood pressure. Those are both better ways to diagnose high blood pressure in Turner syndrome, and we put that in the guidelines. So we recommend that starting at around age 10 or 11, if you're concerned about high blood pressure, that even kids have 24-hour high blood pressure monitors because it's much more accurate. It shows you what you're doing when you're relaxed, what you're doing different activities, and it gives you a much better idea of what your risk is and how to treat it. We do that at our clinic, and most clinics now, at least in pediatrics, have access to high blood pressure monitors and can give you the information that you need to make that decision. So how dangerous is pregnancy with high blood pressure? So pregnancy in Turner syndrome is considered a high-risk pregnancy, regardless of blood pressure. It is considered high risk because there is an increased risk of aortic dissection with pregnancy, and that is true regardless of if you have any other heart problem. So if you're thinking about pregnancy or fertility, going through fertility workup, it's important to see your cardiologist at that point. That's what we put into the guidelines, to get a heart checkup to make sure that everything's okay, and including controlling your blood pressure. In some cases, we might tell you that it's too risky to get pregnant or to carry a pregnancy. And the reason for that is related to your perceived risk to have a dissection. Your doctor can explain that to you, but it's a very individualized discussion. All right, what are the signs and symptoms to watch out for in kids with bicuspid valve? So really for anyone with bicuspid valve, the signs and symptoms that we look for would be things like getting short of breath when you can usually do things without any problem. Getting palpitations, rapid heartbeats that come and go. feeling chest pressure or tightness. If you have any of those problems and you have a known bicuspid aortic valve, it's probably time to get it looked at, because it could mean that the valve is either leaking or sticky. And it could mean that you need to have a procedure done to open up the blood flow in your valve. Sometimes that can happen in kids, but many times this is more likely to happen in adults who've lived with bicuspid valve for many years. All right. Do we have anything else? So let's go to the longer question. My daughter has a bicuspid valve and has an aortic coarctation that was repaired after birth. She sees her cardiologist every 6 months. Everything's going well. We often notice her heart racing. What is known about this phenomenon? So, racing heart is very common in Turner syndrome, even without a bicuspid valve. It's considered to be a problem of the nervous system. So it's called dysautonomia. Some of you might be familiar with that term, or autonomic nervous system dysfunction. It just means that the thermostat that controls your heart rate is set a little bit higher than other folks. From what we can tell, it doesn't have any negative effects on its own, but if you have a heart or blood vessel problem, it could put additional stress on the heart. Sometimes we use medications like a beta blocker to slow down the heart if we think that it needs extra support if you have a bicuspid valve or having other issues. But we don't recommend treatment only because the heart rate is fast. In this case, the issue could be conditioning. Sometimes we recommend physical therapy or exercise because exercise can lower your resting heart rate and also helps your blood vessels stay healthy. Are we done? Okay. Time out. Are we taking a break? All right. Thanks.